For those of you just joining us, welcome to the 17th Annual Cosumnes River College and Sacramento State Center for Practical and Professional Ethics Fall Ethics Symposium. Our theme, as you may already know, for this year is the ethics of providing healthcare. I'm Rick Schubert, Executive Director of the event series of which this symposium is a part. Chairing our third session of the symposium is Hema Asan, an honors student at Cosumnes River College. Emma?
Thank you, Professor Schubert, and good afternoon, everyone. Thank you for being here. The third session of our symposium is entitled Distributive Injustice, Race, Age, and Government Healthcare Spending. Our presenter is Melissa Alexander, a professor at the University of Wyoming College of Law. Her scholarship focuses on the intersection of bioethics, health law, and public policy. She received her Bachelor of Arts in Philosophy with distinction from Yale and her law degree from University of Virginia School of Law. As was the case earlier today, our session will be an hour and 20 minutes long, roughly divided equally into two sections: the speaker's presentation and the question and answer session with you, the audience. As a segue between Professor Alexander's presentation and the open Q&A, we'll hear briefly from two formal respondents: Nalia Pumasacho, my fellow CRC Honors Program student, as well as Gavin Prasad, assistant professor at the University of Denver Sturm College of Law. Now please join me in welcoming Professor Alexander to the podium.
Good afternoon. Thank you for having me here today. And I apologize if a few of these things are points that have been covered by earlier presentations. These are some of the benefits and detriments of going third. But my thesis today is that distributive justice and health equity compel the government to allocate healthcare spending to maximize benefit based on empirical evidence with adjustments for equity. Okay, so maximizing benefit as the goal and adjustments for equity, because we know that even if you create as much benefit as is possible, in order to be equitable, you have to be sure that the distribution of that benefit is also fair. It matters not only how much benefit, but who benefits. So in applying this, I want to focus in particular on how far afield we are from this goal today. In doing so, I focus on Medicare. Medicare is the government assistance program that helps people in this country who are age 65 and older or who have permanent disability. Set aside the people with permanent disability for purposes of my presentation. I'm going to focus instead on the part of Medicare that provides a blanket age-based preference for those 65 and older, and the fact that that Medicare program is legally forbidden from taking into account cost-effectiveness research. Okay? And I'm going to argue that this structure lacks normative basis, i.e. it's unethical. It squanders resources, so it's inefficient. And further, it both perpetuates and even exacerbates existing racial health inequalities. So here's the outline of my presentation. We're going to start by talking about problems with the US healthcare system generally and Medicare in particular. Then I will talk about the thesis I just described in more detail. And finally, I'm going to evaluate the Inflation Reduction Act of 2022. So just this fall, we had new federal legislation, and I want to talk about what that legislation did with regard to distributive justice and racial health. Okay? So you've seen different representations of this same fact, but when you think about healthcare in the United States, one of the most important things to understand is that we spend twice as much money as our peer countries do per person, right? So, you know, here you've got Canada, the United Kingdom, France, Germany, and Japan, but really you could list 20 countries on this slide, and we unfortunately would be the ignoble ones spending twice as much, because in fact the United States does literally spend almost twice as much as the average high GDP country per person on healthcare. In and of itself, that's not necessarily a bad thing, right? Sometimes you have to pay a lot to get a lot. But as discussed in some of the earlier presentations, that doesn't appear to be what's happening in the United States, right? So we're going to play a little around the world game of who has the longer life expectancy. So you've seen some other slides now. Who has the longer life expectancy between the United States and Japan? Japan, right? By more than 7 years, okay? Who has, you know, Asia, maybe they're just doing it better than us, right? We all know sushi's healthy, you eat fish, you eat rice, less bad food, maybe that's the secret. So we'll go to a different part of the world. Who has a longer life expectancy between the United States and Uruguay, country in South America? Uruguay, right? What about the United States and Albania? Albania, thank you. What about the United States and Lebanon? Anybody know where the United States ranks? I mean, at this point in the day, you all know not well, right? But anybody know what our rank is globally for life expectancy? We're 54th, right? So I start with this because I want you to understand that we can't keep doing what we're doing. What we're doing doesn't work. We're spending twice as much for terrible results. And I want to acknowledge that the rest of my presentation talks about access to healthcare. And access to healthcare is important for life expectancy, but it's not the only thing driving our terrible life expectancy numbers. We know that the social determinants of health and behavioral choices in particular also play a large role, and in fact a larger role than access to care. Okay, so I led with my basic thesis, so you know where I'm headed. But I want to give you just a little bit of background for why I would pick on such a beloved program, right? Medicare is a very popular program. It's not like Medicaid. People are always talking about, maybe we should cut Medicaid. But everybody likes Medicare. If they talk about Medicare, they're talking about expanding it and making it bigger. So am I just evil? No. The idea behind this paper started because I'm still on, my state's state medical ethics committee that advises the Department of Health on crisis standard of care allocation. So when you think about the nameless, faceless people during COVID that were determining who gets the ICU bed when there's not enough for everyone, who gets the ventilator, who gets the vaccine, who gets remdesivir, who gets every limited resource, and why, those are people like me. I was on that committee. And so being forced to make really difficult distributive justice. You know, I'm a philosophy major. When I was your age, I was studying philosophy, right? But it's a very different thing to have to make those kinds of decisions when you know that real people are going to die as a result of the decisions that are being made. And so I took the job very seriously, and I got my hands on as many different state crisis standard of care plans as I could, and I did academic research on, you know, what are the ethicists and other academics saying is the best way to distribute these. And it was very clear that the overwhelming majority, 96% in fact, had the goal of maximizing the benefit, right? So the overwhelming number of crisis standard of care plans sought to maximize benefit as their primary goal, okay? That maximization of benefit was driven by evidence, so it was also very important to these plans from an ethical perspective that this benefit was based on as best empirical knowledge as could be found. Benefit was typically measured in two different ways. Number one, the likelihood of benefit, which for ICU beds tended to be based on SOFA score. Longer discussion whether that's good, bad, or sideways, right? But you were looking at both likelihood of benefit and then somewhat more controversially and less commonly, but also looking at duration of benefit, right? And the idea behind duration of benefit was your first goal was to save the most lives, but your secondary goal was to save the most life years. Okay? And so this was the idea that if someone was going to die independent of COVID, and independent of getting an ICU bed, if they were going to die tomorrow anyway, and someone else, if they got that ICU bed, could live for another 50 years, that if those two patients had an equal likelihood of benefit, then that duration of benefit meant the bed should go to the person who could live 50 years if you gave it to them, instead of the person who could only live one day, right? You also saw in some of the plans life cycle fairness as a tiebreaker, and we'll circle back to that life cycle fairness a bit later in the presentation. Another thing that was quick and easy to observe in these plans is that they did not categorically exclude anyone based on age, at least mostly. There were some that actually did, and it was against people who were of advanced age, and I oppose that as unethical. In other words, there were plans that said, if you're 80 or older, you can't have that bed. We're going to give it to younger people, and those, again, I think are ethically problematic. We know that age is not a very close measure of likelihood of benefit when it comes to medical need. But what none of them did is none of them prioritized the oldest Americans, the Americans of advanced age, over Americans who were younger, right? Some did the opposite, but none did that. So why, in our day-to-day healthcare system, do we have a blanket prioritization for Americans of advanced age? It doesn't make any sense. I think the first explanation is that during COVID, when we had to come up with crisis standards of care, we had to acknowledge the reality that we were licensing. That we were rationing, that there, in fact, were not enough beds, vaccines, other resources for everyone. And in the United States, we like to pretend that we do not ration healthcare. The idea of rationing healthcare makes people feel very uncomfortable. They want to believe that healthcare is not rationed, but it's simply false. If you look at the latest Pew research, it suggests that 1 in 3 Americans report having to forego needed, recommended health care because they can't afford to pay for it. 1 in 3, okay? If you think not just about foregoing care, but about delaying care, the numbers are even worse. 40% of Americans report delaying health care that's needed in the last year because of cost. Healthcare debt is the leading cause of personal bankruptcy in this country. And it's important when you understand the extent to which the U.S. rations healthcare, and it rations based on the ability to pay, that this includes people who have health insurance, right? A third of the United States does not lack health insurance, but even with insurance, healthcare in this country remains largely unaffordable to vast swaths of the population, and that is due to narrow coverage and cost-sharing obligations that are unaffordable. During COVID, when we were forced to actually acknowledge the healthcare rationing that goes on, we then insisted on evidence, cost effectiveness, so that we could maximize benefit. We wanted to get the very most we could from the limited resources we have. We have to start acknowledging that we're rationing care in this country, and we have to start using empirical evidence to maximize the benefit of each dollar that we're spending on health care. The United States is one of the few countries that fails to do this. Other countries globally have national comparative effectiveness agencies. The United States does not. One of the other things that we have to do is we have to be sure that the division, that the money that we are spending is being fairly distributed between people. This is the equitable component or adjustment. And this, unfortunately, was lacking in many of the COVID crisis standard of care. Okay. So in fact, even though I've told you we ration care, and I've told you that we ration it primarily based on ability to pay, we know that the government in this country subsidizes the cost of care for millions of Americans. My presentation today focuses on the subsidy that exists under Medicare for Americans ages 65 and older, regardless of wealth and regardless of care cost effectiveness. The result of Medicare is that more than 99% of Americans age 65 and over are insured. This is dramatically more than non-elderly adults. If you look at the percentage of adults ages 18 to 64 who have health insurance in this country, rather than the over 99%, we have 13.5% of non-elderly adults with no health insurance. Many people view Medicare's age-based rationing as a non-discriminatory approach, but that is to ignore its overwhelmingly disparate impact. 75% of Medicare beneficiaries are white, non-Hispanic. Contrast that with a population of this country which is only 59% white, non-Hispanic. Many people justify Medicare because they say, now wait a minute, I paid into Medicare my entire life, right? It's taken from a payroll tax. So this isn't like Medicaid. It's not a government assistance program. Well, to some extent, that's true, but overwhelmingly, it's false. The average Medicare beneficiary receives $3 for every $1 they contributed. There's no question that the ethics are different for the money people actually paid in, right? That's not what I'm contesting today, but that's not the overwhelming percentage of our current Medicare dollars. It's a government assistance program. It's just wearing a different dress. When you think about the fact that Medicare is not means tested, well, I shouldn't say it's not means tested because that's not totally true. You can participate in Medicare, you can be a beneficiary, you are eligible regardless of your income and regardless of your assets. The result of that is that 5% of Medicare beneficiaries have six-figure incomes. 5% of Medicare beneficiaries have more than $1.4 million in assets available to them. So this is not a program that is restricted only to people with financial need. It is also not a program that considers cost effectiveness, and in fact, a quarter of Medicare dollars are spent in the last year of life. Contrast this with the federal government assistance program that's designed to help low-income Americans. That's Medicaid. And Medicaid does, in fact, help millions of low-income Americans. But it's important to understand that there are millions of Americans who are low-income, who can't afford health care, who can't afford insurance, who are unable to be eligible for Medicaid, because Medicaid has income restrictions everywhere and has categoric restrictions in states that have not yet expanded Medicaid. So there are currently 11 states that haven't expanded Medicaid, so more than 20% of the United States have not yet expanded, including high population states like Texas and Florida, right? And so there are millions of people who can't receive the care they need in the country right now. And non-elderly adults are being forced to forego recommended care at significantly higher rates than those people ages 65 and older. You have 30 million non-elderly adults who are uninsured. And I want to make two comments about that population. And the first is that if you look at the 30 million Americans who are uninsured, 2/3 of them identify as Black or Latinx. And people sometimes like to make arguments about Medicare being designed to care for Americans of advanced age because they can't work anymore, whereas Medicaid, we want to force or incentivize people to work. And so that explains, for some people, the difference. I think what this ignores is that 3/4 of people who are receiving, or 3/4 of the uninsured population in this country are in households with a full-time worker. So either they themselves are working full-time and just not at a job that has those benefits, or that has those benefits at a price that's affordable, or sometimes you have families, obviously, with younger children and unaffordable unaffordable child care results in the household being uninsured. Okay. When you think about these statistics, it is worth noting that Black Americans are almost twice as likely to be uninsured as white Americans, and Latinx Americans almost 3 times as likely. This probably, if anything, understates the racial disparity of our current healthcare structure, because we know in this country that white families have 8 times the average wealth of Black families and 5 times the average wealth of Latinx families. This is perhaps no surprise if you're familiar with the wage gap statistics. A Latino woman is paid only 54 cents for the same job with the same experience and the same education as a white male. An African-American man paid 87 cents for that job. Income inequality ends up being corrosive inequality with our healthcare structure. The results are overwhelmingly bad. Black maternal mortality rates are 4 times higher than white non-Hispanic rates. Black infant mortality rates twice as high. Black children die from asthma at 10 times the rate of white children. Latinx, American Indian, and Black Americans have diabetes at almost twice the rate of white Americans. Black men are diagnosed with HIV at 9 times the rate of white men, Latinx, men 3 times the rate. And when you think about a program like Medicare that is tied to age, it's really important to understand that Black Americans die 6 years earlier. So they literally are going to be eligible for Medicare half as long as their white counterparts. If you look at the lowest 1% of income, Americans die 16 years earlier when they're in the lowest 1% of income than when they're in the highest 1% of income. The result of that is that those who most need Medicare will never live long enough to be eligible for it. So the reform is to distribute resources more ethically and efficiently by prioritizing the likely benefit of each healthcare dollar we spend, after making adjustments when necessary for equity. One of the first things to understand is that there is not, in fact, an ethical justification for the current blanket age-based priority to Americans of advanced age. Certainly not over others who have equal or even greater need and potential benefit. When you talk about Americans age 65 and older, they have not been historically disadvantaged, right? They are older. If anything, we all hope to one day get to be 65 or older, right? So this is not a group that has some sort of homogeneous trait that would entitle it to special advantage, right? Because we know that when you think about distributive justice, usually you start from the premise everyone should receive equal shares, and then you make adjustments if someone has received less than their fair share in the past, right? Because that's only just, only fair. That doesn't apply, at least across the board, based on age. Second, this group is not the least advantaged. Many people who are of advanced age are healthy, wealthy, and powerful, right? It's important to understand, and all you have to do is think about the US Senate, right? If you want to think about what that group might look like. This is not to suggest that there aren't people age 65 and older who have an overwhelmingly strong ethical argument for healthcare dollars, for government healthcare spending, right? There's no question that many, many Americans applying the idea of likely benefit and equity adjustment who are age 65 and up would still qualify, right? But the important thing is they should qualify based on the benefit achieved from the dollar and the equitable distribution, not based on age alone. Life cycle fairness favors the youth. So the idea behind life cycle fairness is that it's maybe in some ways a way of thinking of the youth as the least advantaged. We all hope to have the opportunity to live long lives, to get to live through each life cycle. So someone who hasn't yet had that opportunity, if they die at age 18 instead of at age 80, suffers an additional tragedy or loss. That's the idea behind life cycle fairness. It's sometimes referred to as the fair innings rule. So there's not an ethical justification to prioritize the elderly. In addition to that, it's not good stewardship. If our goal is to maximize the benefit from each healthcare dollar we spend, because in fact there's so much unmet need, then we need to acknowledge the fact that, again, I wouldn't take age into account at all because age poorly correlates to need or to benefit. But if you are going to look at age as a gross generalization, people of advanced age are actually less likely to benefit from a given medical intervention. To the extent they do benefit, they're less likely to have the same duration of benefit because even if they have the benefit, they are less likely to live the same number of future years. And they are also less likely to have dependents who are relying on them, and so they're less likely to have a multiplier effect for the dollars that are being provided. Now, just to be clear, there are, of course, times and reasons that even when something doesn't maximize efficiency, it might be justified, but we've already discussed that that does not apply here. Okay, if you switch to the benefit-based rather than age-based distribution, you're going to dramatically improve health equity. And this is because of the reality, as hopefully clear from the earlier slides, but that when you talk about racial minorities in this country, they tend to have more chronic health conditions, they tend to be younger, they tend to be more likely to be uninsured and have fewer monetary resources. So when you switch to you have to have financial need and we're going to try to maximize benefit, that's going to dramatically move government health care spending in ways that are going to help address health equity. So how does the recently passed Inflation Reduction Act of 2022 line up with the new sort of proposal I've made? The short answer to that is that I do think the Inflation Reduction Act targets racial disparities. I think it charges overspending or overpayment. And I think it charges very real access gaps. But that doesn't change the fact that the overall impact of the Inflation Reduction Act is to increase age-based preference without regard to financial need or medical benefit. So the Inflation Reduction Act was broad legislation. It had climate and it had tax implications as well as some of the health implications we're going to talk about today. And I think I only have 5 more minutes of my lecture part, so I'm going to speed this up a little bit. But the 4 primary health changes wrought by the Inflation Reduction Act are, number 1, and my favorite part, it extended health insurance premium subsidies. And so this made health care more affordable, and it is the most important part of the act that applied to people who were not part of Medicare. Okay? The second part is that they lowered prescription drug costs for those who are participating in Medicare. They capped Medicare premium increases, and it also expanded certain low-income subsidies for the Medicare. So when you talk about extending the premiums and insurance premium subsidies for non-age-based, there's no question that this improves health equity. It helps the large portion, the 30 million are still uninsured, and I guess it just preserves the status quo. But it certainly helps non-elderly, lower-income adults, especially those ages 50 and over. It enables, they estimate, 2 to 3 million Americans to remain uninsured, and it disproportionately helps racial minorities. So this is, in my opinion, a great thing, although it only takes us to the end of 2025. And it's also important to note, I don't disagree with Professor Bailey. For those of you who were able to hear his talk earlier, it's just a Band-Aid. Subsidies are a terribly inefficient way for our healthcare market to operate. So that's not to say that I don't have qualms about subsidies, but it's a needed Band-Aid at present. Okay, so I want to talk about a little bit about the drug cost reforms. You had 5 drug cost reforms. Number 1, a drug rebate tied to increases over inflation. So when drug companies increase the cost of their drug at greater than the rate of consumer inflation, Medicare is going to seek a rebate. Medicaid's been doing it. This is just a kind of forced cost control measure. And so we won't talk a whole lot more about that. I personally think it is a positive thing for the government to utilize its purchasing power, although it's a little bit hard to know with the drug rebate. It's an empiric question that I don't purport to have the answer to, whether this is just going to increase launch price, cause non-elderly populations to subsidize, or conversely, it could have a positive spillover effect. The jury's still out on that one. It caps insulin copays, it eliminates vaccine cost sharing, it caps drug cost sharing prices, and the part that got the most press is that the government's going to negotiate drug prices for certain drugs starting in 2026. I won't have any more to say about that. That part's about not overpaying and only for monopolistic drugs that meet sort of very narrow criteria. I'm in favor. Okay. When you talk about capping insulin copays, I think it's important to realize that this is a targeted initiative. Black and Hispanic Americans have higher rates of diabetes, they have higher prescription drug costs, and they have higher rates of non-adherence to prescriptions due to costs. So the idea of making the cost of diabetes medicine more manageable will disproportionately help this subpopulation if they're lucky enough to make it over the age of 65. The problem, of course, is that it is still age-based. They did try to have it passed so that it would not be age-based. That was unsuccessful. So realize that while this has some benefit, it is exacerbating the age inequity that's been discussed. It is also a disease-based preference. In other words, I think it's easy to think about people who have diabetes. We know that by the time you reach Medicare age at 65 and over, 29% of Americans have been diagnosed with diabetes. So it's a high percentage of this population, but it's a disease-based preference too. So it's not clear ethically why we should treat people who have diabetes differently than people who have cancer or MS or other health conditions that cause them to have unaffordable medicine, right? One possible answer here is insulin's cost effectiveness, but that is a concern. Okay, we eliminate the vaccine copay. This is also an example where they did it a little bit beyond Medicare. The vaccines are all cost effective, so that's all good. This is the most controversial part to me, which is they are capping the drug cost sharing costs. So in 2024, it's going to be capped at $3,000 a year, by 2025 at $2,000 a year. Again, same sort of story to tell about Black and Hispanic Americans having higher rate of prescription drug spending and non-adherence due to cost. But keep in mind, 75% of people who qualify for Medicare are white, okay? And there's no cost effectiveness here. So when I evaluate this plan, I think about the Aduhelm, the drug that was discussed earlier today that is designed to treat Alzheimer's, right? And it's controversial because it's really, really expensive. It's got some safety problems, and it probably doesn't work. It's probably not effective. You got one study that says it's not effective. You got another study that says it's really, really minimally effective, and we know it costs a lot, okay? When the FDA approved Aduhelm, the result was a 14.5% premium hike in Medicare premiums, okay? And the Center for Medicare and Medicaid attributed half of that premium cost to that single drug alone. Well, as long as Medicare refuses to take into account cost effectiveness, as federal law currently prohibits, if you're going to cap the costs people are paying and you're going to allow really expensive drugs to be provided, You're significantly increasing the age-based preference. You're getting even less money for every dollar that's going into our healthcare system. So you're exacerbating the very first slide, the amount we spend. All of this is without regard to the need or the financial need of the individual beneficiary. So I have significant reservations about the overall distributive justice and health equity impacts of this. Increasing low-income subsidies, that's good. Cap premium growth, that's bad because you don't want them making choices eventually, because right now this cap wasn't in place. With the Dualim, CMS ended up deciding to limit the use of the drug to people who were in clinical trials for Medicare's payment. And by doing that, it was able the following year to lower premiums. Well, would that same choice have been made if the premium cap hadn't gone up to begin? All right, I won't respond to critics other than the critics in the room since I'm out of time.
Thank you, Professor Alexander. We will now hear from our formal respondents. After each, Professor Alexander will have the opportunity to reply. And after this, we'll open up the floor to you all, the audience, for any questions and comments you may have. Amelia?
Is this on? Okay. So you mentioned how when it comes to age-based, I believe it was Medicare, many of the Black and Latinx elders are only alive to receive about half of the time that they can spend on Medicare. And so do you think that Black and Latinx elders who have historically not had access to health care, should they receive additional reparational health care, even though they might not have the same benefit as, say, a younger person would?
Exactly. That's the idea behind when you talk about the equity adjustment. We know that populations that have not received their fair share of prior distributions are going to appear to benefit less. And so the only just distribution would account for that and make adjustments accordingly.
Is there anything else you would like to add?
So how would you go about defining what group of people need more healthcare benefits based on historic events?
Yeah, so this is an area where I think more work needs to be done. And I do think that it is very, anyone who looks at affirmative action and its successes and failures recognizes the challenges of operationalizing ideas like an equity adjustment. And I think that we need to do a whole lot more work in this area. I don't purport to have all the answers. I will tell you the two sort of groups I have in mind are, you can look very clearly at the racial health disparities and past both de jure and de facto discrimination, and so that is one group. And then the other group that I think very clearly qualifies for equity adjustment is people who have significant disabilities are also going to need to have an equity adjustment to be treated fairly.
You believe that the U.S. government doesn't want to consider cost-effective research in their Medicaid and Medicare plans because it would require looking into other areas where reparations might be needed, not just healthcare, but in education? Do you believe that they want to avoid that can of worms? So that's why they avoid using the information?
Well, I think the opposition to cost-effectiveness research is their death panels, right? They're politically unpopular. The idea that because someone has a comorbidity, another illness, or are of advanced age, that we wouldn't save them when we can. It goes back to the whole head in the sand that we're not willing to acknowledge that we ration care. And so as a result, we continue to do so. We just do it really, really poorly. I personally would rather acknowledge that we don't have everything that everyone might like, but I would rather get more bang for the buck with what we are spending.
Thank you. I appreciate that. No further questions.
Thank you, Nalia. Professor Farsad, would you like to add?
All right. Yeah, so it was so valuable to hear from someone who also has the perspective of being on a policy-making or regulatory body for the crisis standards of care. And so I wanted to ask something. One was to understand a little bit more about what the structure of the alternative, instead of Medicare, Alexander Care would look like. Is it that it would be a sort of means-tested eligibility based on financial need? Would it be universal eligibility? You sort of were very critical, and I think in some ways I'm not the best questioner because I agree with you about a lot of this. We're very critical of having age-based eligibility because of the way in which it can magnify disparities having to do with life expectancy. But would age have no role at all, or would it just be pared back? So hearing more about the contours of what eligibility would look like would be helpful. And the other thing, which I'm just curious to ask you as someone who's had this experience of sort of being in contact with actual policymakers, is I found the normative case you made, the ethical case, for moving away from this age-based eligibility regime very compelling. But I was curious at sort of where the rubber hits the road in terms of legislation. What would say, your state or federal legislators say about your proposal if you brought it to them? What are things that might be sort of the most realistic changes given the path dependence of our legislative structure and the difficulty of making reforms? What are the incremental steps, if any, that might help mitigate some of these inequities that you point out in the current system?
Yeah, so I think I'm going to try to take your questions in reverse order. The two things that my paper starts with in terms of incremental change, one of which was contained in the Inflation Reduction Act, which is I really think until we fix the whole kit and caboodle, having premium subsidies for people who are spending more than 8.5% of their income on health insurance is just a must. And again, I describe this as a Band-Aid because I think it's a terrible sort of long-term solution, but I think it's really important in the short term. What did not make it into the Inflation Reduction Act that I recommend and was proposed in the Build Back Better Act was some kind of program for all those people who are either not income eligible or not categorically eligible in the non-expansion states. So if you think, for example, about an adult who lives in Wyoming who is hardworking but working at a job that doesn't include health insurance, that individual is not eligible for Medicaid if they don't have kids. They're just not categorically eligible unless they're blind or have a disability. Someone who is a non-elderly adult will not qualify regardless of how low their income is. They're just categorically ineligible. Even if they are caring for young children, the cutoff's at about 40% of the federal poverty level. And that contrasts with, we know that up to 400% of the federal poverty level, you're significantly less likely to be able to afford health insurance or health care. So not remotely able, to put the 40% in perspective, newly eligibles under the Affordable Care Act, anyone up to 138% of the federal. So that's where I would start. And in terms of what do the politicians say, I mean, I think it's a question to them about, I don't think I emphasized here, but my theory is a comparative justice theory. In other words, it looks at how we're treating one group as opposed to another, assuming that you can't spend more on health care and help everyone, right? So a lot of politicians would say this isn't a zero-sum game, we just did something wonderful that really was important and needed to be done for older Americans. And yes, there's this other group that we really need to help too, and we still have work to do, but it's just a matter of political reality. We have to do what we can. Medicare's popular, everybody likes it, and so we got done what we could get done. I mean, my response to that is, I guess, number one, it's not okay. Inequality and exacerbating inequality is actually harmful. And those groups that are being treated inequitably are in fact made worse off by growing the pie and further privileging the already privileged. In addition, I think it is unjust when you have tyranny of the majority acting to further benefit the majority. And last but not least, perhaps the most unassailable, is just there are opportunity costs, right? The more you grow this benefit, that has real costs. It has costs within the healthcare system, but it also has costs for the individuals who are paying for it. And when the political environment changes, and so you may be able to do more for another group, you're still having to pay that. The deficit's grown, you've got other issues. So I don't personally buy the idea that this is cost-free, but I think that's what people would say. And you asked one more question.
Oh, it was just about, I think, the practical one of, are there incremental changes that are possible to move away from some of them? And the other question was about, one question was about this issue of incremental change, and the other was about what the eligibility criteria would be in your system, because you've fleshed out, often in normative ethics we look at what's wrong with the status quo, and you've done a really nice job of laying out what you think is the injustice there. And I'm curious about, for the positive proposal, who would be eligible. In some places it sounded like it might be universal, although the content of the benefits would be more limited than currently. At other places it sounded, when you were critiquing Medicare, that maybe you thought there should be some kind of financial need or a means testing element. And I wasn't sure if there were other eligibility criteria as well. So.
Yeah, so that's a great question. I mean, if this is Alexander care, I would love to see some sort of at least baseline universal care. I believe that healthcare is like education. It is something without which none of us can realize our life goals and realize our personal utility, our view of what it means to have a good life. And so I would love to see healthcare, at least at some baseline level, become universal. I don't think that we have to go there, all the way there, in order to dramatically improve distributive justice and health equity, though. I think not only do we have these incremental steps, and my incremental steps, as you probably noticed, are all need-based. And I think if we're not going to have a universal program, that I would have that as a gateway.
I have one other thing I would be curious to ask, but also if the line develops, just that, so from the crisis standards of care perspective, something that stood out to me was that you're absolutely right that for the ventilators and the ICU beds, which ended up being, in some ways, states were more reluctant to actually enact those crisis standards. Age wasn't used generally as a priority criterion. But for your vaccines and your Paxlovid and antivirals, it absolutely was used in a way that advantaged older adults in accessing vaccines earlier and accessing those antiviral treatments earlier. And I can imagine, my own view is I think there's some case for having that priority because of the correlation between age and being more vulnerable to worse outcomes. But I'm curious about whether you think the practices that existed in so many states, I don't know about Wyoming, of making vaccine access a categorically cut off at 65, or for the Paxlovid, something like that, how you might have reformed that in your framework.
So I actually argued early and often for an age-based preference in vaccines because it's evidence-based to maximize the benefit of the vaccine. And to be clear, the problem with age-based distribution of Medicare is that it doesn't, in fact, correlate closely to need or to benefit either one. When the evidence suggests that age does, in fact, link closely with benefit, then I think it's an appropriate consideration. But the key is to follow the evidence rather than to have a blanket age-based priority.
That's it for me.
Thank you to our formal respondents. The floor is now open to you, the audience, for any questions and comments you may have. Professor Schubert will be your moderator.
Thank you, Hema. As mentioned previously, this event is being recorded for broadcast on Access Sacramento, public access television and radio. In order to ensure that your comments and questions are captured well, please use the microphone to stage left to offer your question or comment. Michael.
Hi, I'm an honor student in criminal justice at Sac City, honor student in political science at CRC, and honor student in legal assisting in the law at ARC, American River College. And I'm also the only disabled who could cite the whole Constitution. I'm also on Medicare because of my survival benefits off of my deceased adopted mother, who is a legally blind constitutional law and family law attorney. And I wrote my mom's court case speeches at 6 years old, despite not having a law degree. And you don't see a lot of child apologies in the law like that. And as a Medicare, and I'm also on SSI, Social Security, so I get Medi-Cal, and which is Medicaid too, so I get both. And so what is this have to do with people my age? Like, where my age, being a disabled and even low income on SSI and Social Security, where does this stand on for people like my age? Which I'm only 46. I just turned 46 in October this year. I was born in 1976.
So if you currently are a dual eligible, then this wouldn't help you because you're already eligible. It really is more likely to help the vast swaths of non-elderly adults who can't currently afford care. Thank you for your question.
So we do have a few other age-based programs. You mentioned Medicaid or SCHIP sometimes having a preference for children. More recently with the Affordable Care Act, we have the dependent coverage mandate, which expanded family coverage to be able to cover people up to 26 years old. So we do have some of these preferences for the young, preferences for the old. You may have partially answered this already. You said you're not categorically opposed to age-based restrictions if they have good evidence. I guess I just wonder, what do you think about those programs for the young?
So generally speaking, my preference is to follow the evidence to maximize benefit and adjust for equity, right? That's the driving force, and I would prefer that to any blanket age-based cutoff. But I do think that if you look at some of the ethical problems of applying the priority we currently give to Americans of advanced age, some of them apply equally to the young and some of them don't. So if you think, for example, about life cycle fairness, I think that the tragedy of a 10-year-old dying for most of us is extreme in a way that when someone who is 85 dies, they have had the opportunity to at least enjoy 85 years. I would love for them to live another 20, but the life cycle fairness of those ages is different. When you talk about the efficiency, again, the reason I dislike age, at least in part, is because it does not correlate well to medical need or medical benefit, but younger people would, on average, benefit more. In addition, when you talk about the ability to work, keep in mind that people under the age of 18 are legally required to be in school, and that's going to limit their ability to work and earn money, which would enable them to otherwise be able to purchase health care.
Thanks. So one measure of efficiency is whether or not the resources are going to the people that need it most. Another worry about efficiency is how many of the resources would be going to a bureaucracy in charge of administering a program. And it's frequently claimed that sort of means-tested programs, or maybe even any very finely tuned evidence-based approach to anything, is going to be more costly to adjudicate and administer. Just wonder if you had a response.
Yeah, I mean, one of the reasons that I have so many caveats when it comes to premium subsidies is because I think of insurance just how you just described. Like, the fact that we have an insurance-based system alone is a failure, because, you know, insurance is priced based on expected loss plus administrative overhead plus profit. So you're losing 1 in 4 healthcare dollars you're spending by running it through an insurance system. And the U.S. system, one of the many reasons that we pay more and get less is because we have a fragmented system that utilizes all of this insurance. So I don't want to create a system that has significant administrative costs that are going to eat into the benefits that we can actually achieve. I think that that is important. But I want to be equally clear that we could do so much better than a flat age-based system. We may not be able to get perfect justice, right? Or the cost of perfect justice may exceed its utility. But we could at least aim at the right thing, and we can harness a lot of the machine learning, the AI. If you look at what other countries are doing to apply comparative effectiveness research, there are ways to do it efficiently, and we just have chosen not to adopt them because we pretend we're not rationing when we are. And we pretend that it's fair that we use age when it's not.
I would like to thank you for your insightful presentation. And the question that I had for you was, you mentioned earlier that low-income demographics have little to no access to health care. But I was also wondering about their access to health care apart from medical health care or clinical health care when it comes to healthy living in general. You know, pricing for healthy food or ways to live in a healthy manner that will probably attain your body in a way that you may not need higher level of medical care that is also inaccessible to low-income demographics. And what are some ways that you would say would be efficient to combating this disparity?
Yes, thank you for your question. And you're 100% correct that where you are born, where you live, grow, and work actually has a greater impact on your health outcomes than your access to health care does. So you're 100% correct that having healthy food, having clean air, having a safe living environment is critical and in some ways, frankly, more cost-effective than the access to health care itself. So there are a lot of people writing and talking about that if anything, the United States overinvests in health care, when what it really ought to be doing is creating a safety net for more affordable and basic services that give people a healthy place to live. And that is unrelated to my expertise, but I believe to be true.
Thank you.
One final question. A lot of the politicians and the lawmakers and the policymakers can't cite the whole Constitution, and plus they are from the rich communities. So they're not low income. They don't have a disability. So, and I'm going to be using reverse psychology. How can you advocate for the low income and the disabled, the homeless, if you've never been there? Like, if you've never been on drugs, how can you properly counsel them? And people with ADHD, like myself, see connections other people miss, and we're naturally creative. And plus, and since I could cite the whole Constitution of the United States by memory, word by word, amendment by amendment, section by section, I could literally analyze those laws within my brain, which makes me a better policymaker to advocate for the homeless and the disabled and the low income, because I've been there.
I think that one of the most important things of any policy is active participation. So if you think you're going to create policy without actually talking to the people that you hope to help, then you're almost certainly not going to succeed. I think that any time you create a policy, it has to be informed not only by empirical evidence, as I've discussed, but also by, what do the people you're trying to help say they need? What do they say matters and will help? If you're not doing that, then it's not going to be successful.
What I meant is, because the thing is, personal experience is better than hearing someone else, because you can't actually literally advocate for them if you've never been there. And that's why it should be people more low income, more disabled people actually running for office. And because we actually been there, it makes us a better voice and more personal experiences to really advocate for them, because we know what it's like to be there. That's why I won for Bakersfield City School District when I was in Bakersfield, because I know what I've been there personally.
Yeah, one of the things that was in the Build Back Better Act from a healthcare perspective that did not make it into the Inflation Reduction Act, which is an example from my perspective of our overinvestment in Americans of advanced age as compared to our underinvestment, at least, of traditionally marginalized populations, is the investment in community health workers, which takes exactly what you are describing and says, we really need to empower and we need to fund people who are trusted community members who know that community, they understand the culture, that understand the problems and the needs, and we need to empower those people. We need to get money to those people instead of people in DC telling other people how it should be. And that's one of the things that wasn't done.
When you're done with this, I would like to probably keep in contact with you guys, especially with my background in the law, and plus with my being a politician too, and self-advocacy for those communities. We could finally make sure my people could finally get justice.
Absolutely.
Hi, can you hear me? Okay. So a lot of younger people really advocate for free, affordable healthcare as a message, but they're not very specific with that. And so I was wondering if that message is being manipulated by politicians to be more applicable to their constituency, that is, like, the majority of their constituency that's participating in politics is the older population. So I was wondering if younger people were more specific about this message, that we could kind of take back how the politicians have kind of manipulated this message.
So if I understand your question, I do think that part of the problem, part of the investment here, is because people who are likely to benefit from Medicare are likely to vote. So one of the things I would encourage younger people to do is, one, you're all here, be educated on sort of the structural unfairness, but two, go vote. Because it won't solve all the problem, but it will definitely help. I think some of the calculation is just a democratic reality of numbers. You can afford to expand Medicare. That is not going to cost you your seat in Congress. If you expand Medicaid, it might. And until that political reality changes, it becomes difficult. But I'm not sure that I think the average American is aware the extent to which Medicare helps wealthier, whiter Americans. I think people think about Medicare and they think that it helps Americans of advanced age, which is a good thing on balance, right? We want to help anyone who needs help. But when you realize that 75% of the people who qualify are white and how affluent some of them are, I think it paints a very different picture. You know, to me, one of the most dramatic facts was the difference when you look at life expectancy of the really low income compared to the high. And I'm not sure if that answers your question.
It does, but I was thinking because making Medicare more affordable for older people, even though they are more, they are already benefiting more, is still making healthcare more affordable. So I was just wondering if we became more like aware that it was just perpetuating this discrepancy, that we should advocate for ourselves more specifically.
I think that talking about making healthcare more affordable is important. I think talking about making affordable healthcare equitable is maybe the buzzword, right? Because the problem is that we know while 1 in 3 Americans forgoes care, that burden is not equally spread, that non-elderly adults bear a grossly disproportionate burden, and that racial minorities within non-elderly adults even more so. And so to me, it's about equity. Nobody likes the efficiency stuff, but part of how you help more people than we're helping right now and get more for the same amount of dollars is to start to look at that cost effectiveness. It's why I think it's so important, even though, you know, gosh, at least people want to be equitable, they don't want to be efficient.
First off, I just want to say that we do need to produce more centurions in our country, no matter their skin color. And that's because they have better stories to tell than some of the younger segment of our population. You mentioned that there exists a disparity in the healthcare system, heavy towards Black Americans. From empirical data reviewed, we know that they're not getting the treatments they need. From anecdotal evidence, Black Americans do not feel comfortable going to see a doctor and would rather find relief in their local community faith-based organizations. The Tuskegee experiments deteriorating their faith in the healthcare system come to mind. We need Black Americans to actively participate in the healthcare system in order to receive the care they need so that we can lower some of the outrageous statistics you presented today. What can the government do to encourage or build trust with this population segment in order to encourage them to actively seek medical treatment? And secondly, if we do get more Black Americans to seek health care, would there be a decrease in per capita spending for health care costs in the United States?
Thank you. In terms of encouraging trust with the healthcare community for Black Americans, you know, I think that the community health programs are a great mechanism. So funding more community health workers can help with that. I think that right now only 2 states require continuing medical education and cultural competency. And I would love to see more states, I would love to see medical schools work on it, but also more states requiring literal continuing medical education and cultural competency. I think we all have implicit bias, and we know empirically that healthcare workers suffer from implicit bias. And so until we start taking some active steps to combat those things, that's really important. Something else that might help with trust is more guideline adherence, more standardized care. We know when it comes to maternal mortality, which is, you know, one of the worst, not the worst, but one of the worst statistics for racial health disparity, that in California initiatives that have required standardized care so that you're treating all patients the same way, and if you don't, you have to document why you didn't, that resulted in a dramatic improvement in outcomes. You get the improvement in outcomes, you're going to start to build back the trust. But I think it's important to understand people can talk about Tuskegee, but you don't have to talk about yesterday. We have problems today, and we're going to have to solve them to reestablish that trust. Obviously, access to care, the ability to pay for it is important too. But I think even if there's access to care, if care isn't acceptable, that's a problem. And do I think it will decrease per capita costs? Probably not, right? At least not in the short term.
One final question. My adopted mom was born in San Juan, Puerto Rico. So what? So when it comes to the United States territory, like Puerto Rico, Guam, American Samoa, Northern Mariana Islands, and the other territories of the United States, how is the access to care over there? Or what type of? Or do they actually have Medi-Cal, Medicare like we do in the mainland?
So I don't know a whole lot about healthcare in the territories, but I think at least in Puerto Rico that they are eligible for Medicare and Medicaid, but I'm honestly not positive.
Hello. Sorry. I'm kind of short.
Me too.
Hi, thank you for your presentation. You mentioned something about subsidies being important in the short term, but not too good for the long term. And I was wondering, how would you go about creating policies are for the long term, or like what's good for the long term? And should we give in to short-term pressures, or is that like, yeah.
Yeah, so as I discussed earlier, if I could just click my heels and make a different world, I would love to see the United States have at least some sort of baseline universal health care. And the example I usually use is of our public education system. I think most people think that our public education system could be better, right? It could be better in the sense that it could extend past 12th grade. And it could be better in the sense that we have failing schools, right? But that having been said, every single person who is in this country can show up for kindergarten and can get an education for free, regardless of their income, regardless of their background, from kindergarten through 12th grade. And I think not only do the individuals who receive that education benefit, but that we as a society benefit. I think that healthcare would be the exact same way. If you had a baseline of cost-effective care that everyone had access to, regardless of ability to pay, regardless of background, not only would those individuals have fuller, richer lives, but all of society would be better.
Thank you.
Unfortunately, we've reached the end of our session. Fortunately, we still have one more session to go today. We hope you'll remain and join us for it. For now, please join me in thanking our presenter, our session chair, and our respondents.